We'll finish the counter and then have audience response.
Good afternoon, ladies and gentlemen. I'm Dr. Jatinder, Bali, and I thank the organizers for giving me this opportunity to talk about RD surgery for the residents. Should it be optional or should it be voluntary? Should it be optional or should it be mandatory? And I am going to support the latter. I have no financial interests in this particular presentation. So the first thing we did was we did a Snap online poll, and the results were not surprising. 90% of, almost 90% of the residents as well as the practitioners, they felt that this was an essential part of training, and this included practitioners in anterior segment as well as in the posterior segment. Of course, all of us know there are 3 different types of surgeries that we are practicing for retinal detachment. And for paucity of time, I'm going to focus on vitrectomy mainly, and then I'll just touch upon the latter too. So now let us look at the Indian scenario. You see, we have 540 odd medical colleges. Out of this, 240 medical colleges are licensed to run MS ophthalmology courses. The total annual intake is around 1,000 odd. In addition, we have diploma courses and we have DNB seats. The sum total of all these seats gives us 1,500 ophthalmic surgeons every year. Now let us dissect it a little further. Out of these 540 odd medical colleges, only 8% or 40 odd medical colleges have fully functional retinal setups. So that means we're looking at 200 institutions which do not have access to it. Then we went back and we said, let's look at the costing data. Now, a VR surgery in the US costs around $4,000 US. In India, we're charging around $500, $550 US. But look at the cost of the consumables there. They're costing $250 to $450 across the board. The per capita GDP of India is 2,000 odd US, and out of this, we're spending around 1.5% on our healthcare. The US spends 18% of its GDP on healthcare. In addition, what is the problem we have in India? We do not have a robust referral system, forwards or backwards. The distances are shrinking because of better roads and better transport, and ambulatory patients can move from one center to the other. So when we look at the costs of acquiring and maintaining this expensive equipment, along with the costs of obsolescence and the recurring costs associated with every surgery, I think it's going to be very difficult to sell this proposition to the policymakers or to any government to increase the outlay. Yes, we are a large market for these devices and machines. Yes, we do want the training for the surgery. The question that we need to answer here today is, can we afford it? And the answer to my mind is that unless we drastically increase the outlay to this sector, or we drastically decrease the cost per surgery, I think it's a pipe dream that we're talking of. That is why we should keep it as optional. Because if we make it mandatory, there's going to be fudging of data because we have to award those degrees. And all that training is going to remain on paper only. And we will be training generations of liars. That having been said, there is scope for pneumatic retinopexy and scleral buckling. And that, I think, should be made available to each and every trainee wherever possible. In addition, there is a need to deprecate this move towards trying to award MCH and vitreoretina, because what it is going to do is it is going to further rarefy the already limited facilities and decrease the demand for the machines as well as the devices. What we need is a win-win situation for everybody and not a win-lose. What we need is sabka saath, sabka vikas. We want it. Can we afford it? Is the answer that we need to answer today. Thank you.
Thank you.